1 in every 3 healthcare dollars spent on cardiovascular disease. The number I have is 800,000 deaths a year, cardiovascular disease. This is big stuff. Schmendrix notwithstanding. I like the use of Yiddish. Well, when we actually look at this, with this much at stake in this country, with this many people involved, we're actually looking at payers, right? We're looking at the folks who have to foot the bill. And so what are the implications of cardiovascular disease? I know you alluded to it going forward. For the payer community, for managed care, what's the cost burden? Who wants to jump in on that?
Yeah, it's obviously it's tremendous, along with oncology and immunologic diseases. Cardiovascular disease is one of the top 3. But when you say payers, ultimately the payers are society.
I was going to say that.
We're basically an intermediary to manage those dollars.
Oh, but wait, that's an easy. I'm not going to let you off the hook
right.
on that one. Oh, sure, the American public has to bear this, but when it comes down to it, the doc sitting across the table from a patient is going to go to one of you guys and say, I want to do A, B, or C. You're the guys who have to, and women, who have to approve or disapprove. You're the sieve, the filter. So to some degree, you're going to make these decisions.
Well, we're going to make the decisions about coverage, and yes, I don't disagree with you.
You don't?
But again, we're going
to make a very short broadcast.
How do you make those decisions?
Well, we make the decisions based on evidence, which I would hope that as a practicing physician, all physicians would base their treatment decisions on evidence. We also make the decisions on coverage based on population medicine, which is something that practicing physicians do sometimes, but not all the times. So
I got to cut you off. I'm sorry.
Okay. But you said
population medicine. So population medicine drives all of our guidelines. It is our RCTs.
It's herd medicine.
Right. And we try to extrapolate from population medicine to the individual patient sitting across from us in the office, and it's an impossible extrapolation. So it's an unfair and inaccurate use of science, and that is what managed care tries to do. That is what even the guidelines do.
It's what our obligation is, though, is to practice population medicine in terms of coverage decisions. I wear 2 hats. I practice as a physician, but I also work as a medical director.
Well, let me play devil's advocate for you. If he gave everybody everything that you guys asked him to give, he'd be broke in a week. And if you gave nobody anything, we'd all be dead in a week. So,
I don't think that's true.
Exactly.
You don't think that's true?
Absolutely not.
Why not?
Well, because I think if every payer gave everything we wanted, then patients would be healthier. And then in the long term, they would have fewer heart attacks, fewer strokes, and they would have longer lives. What happens is, and the insurance companies are very honest about this, the ones I've spoken to, they understand that patients switch from insurance company to insurance company, and they don't want to bear the burden of a particular medication that's going to have its benefit 10 years down the road when the patient's going to be with a competitor. So I think that's a major part of the problem.
I'm going to take this from a different angle.
Oh, please do.
Because I feel that it's not just about coverage decisions that we're looking at, but really the benefit design for patients so that they have access.
What does that mean, benefit design?
So for example, so I'm a pharmacist and I straddle also the clinician perspective. I oversee a group of clinicians who practice within a managed care setting. But there's also the benefit structure that says, okay, the first step in managing cardiovascular disease is lifestyle modifications as well as access to appropriate therapies. So when you look at this from a managed care perspective, you want to make sure that your disease management models within managed care complement what the physician and evidence-based guidelines are trying to do so that you can help your patients achieve their outcomes. Well, not just disease management, but also your formulary structures.
That means you've got to do some stratification, right? You can divide those at risk for cardiovascular related events, and especially high-risk people, into 2 groups, it seems to me. The modifiable group, that is to say they've got risk factors you can fix, and then the non-modifiable risk factors, right? And that's sort of what you were talking about. You got to identify what you're talking about.
Well, for example, I feel that if you have a benefit structure that, for example, wants to promote lifestyle modifications, which could be for all stratification groups, then you need to provide access to weight loss programs. You need to provide access to smoking cessation services that are paid as part of the benefit of your health plan.